So let's begin with the first family. Under Myxoviridae, we actually divided into orthomyxovirus and paramyxovirus. So you should know what members come under each. Orthomyxovirus is the usual influenza that you study about, influenza A, B and C. Whereas paramyxovirus, of course, if ortho guys had influenza, paramyxo will have parainfluenza. So one of the viruses out of these becomes very, very simple. There's another minor one called Nipah virus, which is very famous after 2018. So remember, parainfluenza and Nipah you have learned. Apart from that, you have to learn MMR. What is MMR? It is measles, mumps, but not MMR mein R for rubella. No, rubella does not come under this family. It is respiratory syncytial virus that comes under this family. There's a minor change. Respiratory syncytial virus is now known as human respiratory syncytial virus. Not much of a change, but I just wanted to point it out. So the MMR over here, remember, rubella is not R is not rubella, it is respiratory syncytial virus. And on that note, you should be noting that rubella actually is said to be, earlier it was said to be a kind of a toga virus, but now it is said to be a part of something known as Maternaviridae family. That's the update that we have. It's a part of the Maternaviridae family. So repeating, now let's begin all these one by one. Let's start with orthomyxoviridae family, that is influenza, and this is how the structure looks like. I hope you all remember that all the RNA viruses are unsegmented. However, you remember there was a family called Bira Bora. Influenza had how many segments? It had 8 segments. Can you count? 1, 2, 3, 4, 5, 6, 7, 8. Yes, the RNA has 8 segments. This you studied in your general virology. So 8 segments are in front of you. And if you look at the outer surface, that is the envelope, you will be able to see that there are 2 proteins. One is HA, that is hemagglutinin, which is too much in abundance, so many of them. And then minor ones that you can see are the neuraminidase. So whenever there has to be entry of the virus is mediated by hemagglutinin, whereas whenever the release of the virus has to happen, that is mediated by neuraminidase. Remember, remembering and telling you again, entry ke liye you have hemagglutinin and neuraminidase is going to be from the for the exit. So whenever a virus comes into our cells, maybe our respiratory cells, it will enter via HA, and if it has to come out of the cell, it will come out via Na. Apart from that, can you see 2 more proteins very clearly? There is something known as the M1 protein that you have all over. You can have something called M1 protein, and apart from that, you also have something known as the M2 protein. I want you to focus on this M2 protein. You know why? Because this is the structure that you're seeing in your microbiology lab. Imagine this virus inside your body. Inside your body, do you need all these different things? No, ma'am. Inside the body, the virus has to divide, replicate, make many copies. All that it needs is apna RNA. RNA hoga, virus can make 1 million copies also. So remove all these. As soon as it will come into your body will say remove all these. So who helps in the uncoating of the virus? Who is going to help in the uncoating of the virus when it enters into our body? It is this M2 ion channel. This helps in the uncoating of the virus. So you will say, ma'am, if you give a drug which will not let M2 work, agar M2 nahi work karega, if this will not work, the virus will not uncoat, and if it will not uncoat, it will not be able to replicate in my body. Exactly, we've got drugs. Amantadine and rimantadine are drugs which are against M2, and that is what you have to know for the treatment of influenza. So repeating once again, if this structure is given in a life cycle, lots of these molecules, yellow color molecules that you have, these are hemagglutinin for entry. These green color molecules are neuraminidase for exit. Then you've got 2 more proteins called M1 as well as M2, and I've already told you the M2 ion channel is the one that is going to help in the uncoating of the virus inside our body. So this is your basic. Now let me show you a twist in the situation. Look at this, guys. What can you see? Yes, ma'am, this is one influenza virus. For example, this is virus number 1, just taking as an example. This is another influenza virus. I will label it as 2. They enter into the same host cell. For example, let's take the example of some animal like pigs. So pigs mein kya hua? Influenza type 1 virus also went into the respiratory cells. Influenza type 2 virus also went into the respiratory cells. Can you see a new virus has only formed? A third type of new virus has formed, which if you look carefully, so it has a little amount of RNA of virus number 1 and it has a little amount of RNA of virus number 2. So you'll say, ma'am, ek naya virus ban gaya. There is a new virus that has has formed, and this is known as antigenic shift. So please note, what is antigenic shift? Where exchange of RNA segments would occur. Exchange of RNA segments would occur, little bit of RNA from one virus, little bit of RNA from the other virus, and a new virus is formed. That is what all of you also do. Little bit of micro you will study from one source, little bit of micro you will study from another source, and then you will come out as a new hybrid variety having all the information. That is known as antigenic shift. And S for S, antigenic shift is said to be a sudden change, and this is associated with influenza A. In fact, all the epidemics and pandemics of influenza that you hear about is because of this. Why are we so scared of influenza? Like you were very scared of COVID, now why are we scared of influenza? Because it can undergo these sudden changes. Mix and match hoga, a new virus will form, it will cause all epidemics and pandemics. Primarily they are caused by influenza A. Versus what is antigenic drift? Antigenic drift is, ma'am, kuch mix and match nahi hai. This is one virus only. Either you can change its hemagglutinin or you can change its neuraminidase. So if you end up changing any one molecule, chota sa change karoge, it will convert into a new virus. That's about it. So that is known as antigenic drift. Antigenic drift is either a mutation in hemagglutinin or neuraminidase. It can be seen in any influenza, but it is not going to cause pandemics and epidemics and all of that. It is not associated with any of those features. An antigenic drift is very, very slow. How I have learnt it is, antigenic shift, S for S, it is very sudden. Whereas antigenic drift is dheere dheere. It is very, very gradual that it's going to be there. These are the two variations that you have to know. This is important in PSM also. Now on that note, just imagine, you want me to mention how would a patient of influenza come? I don't think so. Because we all know fever. We've all had influenza sometime or the other, fever, headache, sore throat, cough, muscle aches and pains. But what is usually absent, what you need to learn in this entire story is that running nose is typically absent. That is important for you to know. Running nose in these patients is typically absent. These are all upper respiratory tract problems. Can it complicate and go into the lower respiratory tract? Yes. As a complication, pneumonia is also known to occur with influenza. How do you do the lab diagnosis? Sample क्या लोगे? Common sense, ma'am. जैसे COVID के लिए you were taking nasopharyngeal swabs. For influenza also you will take a nasopharyngeal swab, and we do the same story. We do antigen detection, antibody detection, we do polymerase chain reaction that we are doing for every virus. Now, what is so special about this virus? This virus shows a test called as hemagglutination inhibition test. Just learn the name of this because it is very, very important. It might be written as HAI, heme agglutination inhibition test, is going to be positive in a case of influenza virus. That is the influenza ka pathogenesis, lab diagnosis. What about the treatment? I think regarding M2, I have already told you, you can target the M2 ion channel by amantadine and rimantadine. But what can you usually use? Do we use Tamiflu when you remember that swine flu outbreak and so many influenza outbreaks? So we use something called Tamiflu, which is oseltamivir. O for oseltamivir, O for oral route. This is a drug which is given orally. Apart from that, there is a drug called zanamivir and Relenza. दोनों में क्या आ रहा है? Neza वाला sound है. So this is going to go via inhalation or the nasal route. Easy to learn हो गया. Zana sounds like Neza. Relenza sounds like Neza. So this is going to go via nasal route. Whereas oseltamivir, which is Tamiflu, oseltamivir is going to go via the oral route. And that wraps up your Orthomyxoviridae family. Now I'm going to come into Paramyxoviridae family. Number one, we had something very similar called parainfluenza and Nipah viruses. These were the chota wala viruses that you had. Then you have measles, mumps, and not R for rubella, respiratory syncytial virus. So let's start. Let me start with the major ones. Measles and mumps main wale hai na. Let us finish off those. Measles was a recent FMG and a NEET PG question also, so you have to know measles. Measles is something known as rubeola. Ab na there is all-time confusion. What is rubeola? What is rubella? What is German measles? Let me figure it out once and for all. There is something known as measles. and there is something known as rubella. ये तो पता है, measles and rubella. So अब rubella is not, you can't put another rubella into it. So this is what is called as German measles. This is referred to as German measles. And measles is referred to as rubeola. So cross connection हो रहा है, ठीक है? तो measles is referred to as, तो cross connection type याद रखना. एक बार एक ही measles आएगा, एक बार एक ही rubella आएगा. So if measles is written, don't write German measles, then write rubeola. If rubella is written, then write German measles. One thing to note. Other than that, please note that their incubation periods, I am telling you measles, mumps and rubella ka incubation periods ek saath. So please note that when you are talking about, or better than that, what I can say is I'll give you a table. Why only incubation period? Let me just finish off all of the vaccines also, because then pediatrics is done. Let's talk about measles, mumps and rubella. So for measles, the incubation period is going to be 10 days, right? 10 days as soon as you get a question. Now from the same 10, I want all of you to make a line down, and how many days does it become? For mumps, it's going to become 19 days. Now once you have drawn the 19, from that, please take another danda forward, take another line forward, and for rubella, it becomes 14 days. So repeating once again, this is how you're going to write it in the exam. For MMR, you will write 10 days, then you will convert it into 9, so 19 days, then you will convert it into 4, so 14 days. 10, 19, 14. What about the strains? Remember, for measles, I always, now from today onwards, I will like to call it measles. Okay, we'll write it as Z bana dete. Let's make it measles. Why? Because the strain that we have is going to be the Edmonston-Zagreb strain. So it's the Edmonston-Zagreb strain that we are going to use. So measles mein Zagreb. What about rubella? This is very simple. RA27/3. So RR rubella, RA27/3. Mumps. Mumps mein I will just teach you. There's always a chota sa cute sa bacha. That a photo of a chota chubby cheek bacha is there. So that bacha we have named as Jerry. So the name of the vaccine strain is going to be the Geril-Lin strain. So these are the strains that you have for MMR. So remember, for measles, you have the Z, that is Zagreb strain. For mumps, you have the cute Jerry, that is Geril-Lin, and R ke liye RA27/3. What are the incubation periods? 10, 19 and 14. So this is what we've done. Measles is known as rubeola. Incubation period is 10 days. Now what is the question that came in the paper? This is a recent exam question of 2023 for FMG students. Measles is gonna be the 3 C's. तो क्या क्या होगा? देखो मैम, virus है, fever तो होगा, understood. Other than that, there is cough, conjunctivitis and coryza. Remember, cough, coryza, conjunctivitis. If these 3 C's are written, it is very, very important that you think of measles in the exam. Cough, coryza, conjunctivitis. But what after that? देखो, इंक्यूबेशन पीरियड क्या था मैम? 10 डेज था. तो 10 डेज होते ही what is the first thing that the patient is going to have? Patient will have fever. Immediately 2 days later, the patient has these spots on the buccal mucosa near the molars. Near the molars, along the buccal mucosa, there is spots which are known as Koplik spots, right? And another 2 days later, we start seeing a rash in these patients. And this rash is very characteristic, because when rash will come, everything else is gonna go away. Jab rash hoga story mein, to fever is gone, Koplik spots are gone. So remember, 10th day, that is when the incubation period is completed, fever happens. 2 days later, Koplik spots happen. Koplik spots are seen on the buccal mucosa near the molars. And then we have 14th day, that is rash. And can you see how the rash is happening? As if someone has thrown water on you. Someone throws a bucket of water on your head. First, the water will go behind your ears, and then gradually it will come onto your neck, and then it will go to the body. So first it has gone on the face and behind the ears. It starts behind the ears. Then it's going to go on the entire shoulders, the neck area, and then it's going to go on the trunk. That is how, as if water is falling down. That is the classical rash characteristic. So coming all the way back, when we are talking about measles, kaunsa wala spots likha? We have written Koplik spots, because when you go to pediatrics and when you study rubella, rubella also has a kind of a spots, and those are known as the Forsheimer spots. They are present on the palate. Forsheimer spots are present on the palate, and we will be wanting to know these differences in the exam a lot, because dono mein fever hoga, right? Measles ke के साथ कॉप्लिक स्पॉट्स लिखा होगा, रुबेला के साथ फॉर्शाइमर स्पॉट्स लिखा होगा. ओके, कमिंग बैक टू मीजल्स. तो मीजल्स का क्या हिस्ट्री होगा? देयर विल बी अ कफ, कोराइजा, कंजंक्टिविटिस, 3C हिस्ट्री, देन फीवर, कॉप्लिक स्पॉट्स एंड रैश. बट व्हाट इज अ वेरी इंपॉर्टेंट complication that can occur? There is a CNS complication known as SSPE. So what is SSPE? Subacute sclerosing panencephalitis, and this actually is said to be a late complication. When I say it's a late complication, it's going to occur many years after measles. So for example, a patient had measles right now. How many years later will SSPE occur? Approximately 7 to 10 years later. But the problem is that once SSPE occurs, within 2 to 3 years, it's going to be very fatal. It's going to result in death. So please remember, late complication hai, but once it happens, it's quite fatal. Now, one thing I want to ask you from pathology again, integrating it, was there any cell in pathology which reminds you of measles? Was measles associated with any kind of giant cell? M ka ulta W, yes, M opposite inverted W, Warthin-Fink-Elde giant cell. What is Warthin-Fink-Elde giant cell? Something that had intranuclear and intracytoplasmic inclusions. If you remember this, it had intranuclear. Can you see dots inside the nucleus and also inside the cytoplasm? So you had intranuclear and intracytoplasmic inclusions. Any other virus that shows you intranuclear and intracytoplasmic inclusions other than measles, we have studied just half an hour, 40 minutes ago in this lecture series, and that is cytomegalovirus. Measles and CMV show both IN and IC inclusions. Okay, so measles is done. I think we can go on to the next one, the cute little kid. I told you, I will show you a very cute little kid and I call him Jerry, and that is known as mumps. Mumps is what? So obviously, if I ask you what is the most common feature of mumps virus, you will say, ma'am, nothing. The most common feature is inapparent. Most of the patients actually don't have anything. But when they have a manifestation, I think you can see why is this kid so cute, chubby, because he has bilateral parotitis. Bilateral parotid gland involvement will be noted. What is the second most common manifestation? That is going to be unilateral orchitis. So it means there is involvement of testis, unilateral orchitis, and involvement of bilateral parotid. Imagine just if you say, if there's a bilateral parotid gland involvement that is given in the exam and you are given a child, what is the infection that you will think of? You will always think of mumps. But if you've been given an adult and that adult is a smoker, then what is the infection that you are going to think of? Maybe not an infection, but a tumor, and that tumor in surgery is known as the Warthin's tumor. Remember this dictum forever, it will help you a lot. Bilateral parotid gland involvement hai. Children I will think of mumps, whereas in adult smokers I will think of Warthin's tumor. That is important. That is what you need to know. Coming back, mumps ke liye, I'm not going to tell you the strain. Why did I call him Jerry? Because the vaccine is going to use the Gerryl Lynn strain. We have already done that. We've also done the incubation period, and that was 10 for measles and uska 19 banana tha. So it was 19 day for mumps. Actually, I always study measles, mumps, rubella, but does rubella come under this family? No, rubella does not come under this family. Still, I am teaching you rubella over here because pura vaccine ho jata hai na. So let me teach you rubella, and I think I have already told you, rubella is also now, earlier it was on the Togaviridae family, but now it is said to belong to the Metonaviridae family. I think this information also I have given you, that measles is known as rubeola, rubella is known as German measles. I think I have also told you the spots. So if we study rubella, firstly, what is the incubation period? Again, let me ask you your mnemonic, measles, mumps, rubella, pehle 10 hoga, then 10 ka 19 hoga, and then 19 ka 14. So what is the incubation period for rubella that we have? We have 14 days. What all does these patients have? First and foremost, it's an upper respiratory tract infection. There is a post-auricular lymphadenopathy. There is a rash that you can see over here in these patients, and you can see some red color, pinkish red color spots on the palate. What are those spots? Fordsheimer spots, and that is what I was telling you. In measles, what were the pathognomic spots? Measles mein most important are Koplik spots, whereas in rubella, what is important? It is the Fordsheimer spots, which are non-specific but are quite important for your MCQ. So that is how you remember measles versus rubella. But If you talk about pediatrics, all this information will just go through wala information. What is important from pediatrics is the rash. This rash tends to last for 3 days. This rash classically lasts for 3 days, and that is why we also call it a 3-day measles. Did you notice in the previous slide along with German measles, I had written 3-day measles because the rash lasts for 3 days. That is a pediatrics question. Another pediatrics question is, can this go from mother to child? Yes, mother to child. Congenital rubella syndrome, CRS, is very, very important. What is congenital rubella syndrome? So rubella sounds like Rona. Number one, Rona. Who is going to cry? Someone who is blind in love. So remember, प्यार में अंधा बहरा. That person is going to cry. Never go blind in love. ठीक है? तो प्यार में अंधा बहरा means what? प्यार में means that this person is going to have a heart problem, patent ductus arteriosus. अंधा बहरा means that there is a cataract, and बहरा basically means there is sensory neural hearing loss. So remember, प्यार में अंधा बहरा is going to cry, that is rubella. But also remember, Bella will remind you of blueberry muffin baby. So can you see these spots that are present which are giving it a characteristic blueberry muffin appearance? So remember this as well. I'll repeat the mnemonic for you so that you don't get confused. Rubella means Rona. Pyar mein andha behra is gonna cry. So pyar mein patent ductus arteriosus, andha for cataract, and behra is going to be for, we have the sensory neural hearing loss. Next, Bella will remind me of blueberry muffin baby that is formed over here. But one question which I want the INI-CET students to note, in congenital rubella syndrome, do you know the virus? The virus is shed in the saliva and the urine of the baby. So whenever there is a congenital rubella syndrome baby, look out for the virus in the saliva and the urine. That is what is important from INI-CET point of view. So now rubella was not a member of this family, but humne kar liya. But what is actually a member of this family with R, what you actually had to know was respiratory syncytial virus. So break it na. Respiratory syncytial virus, first and foremost, ma'am, it is quite common in R for R, that is the rainy season. Next, it is going to cause respiratory problems. So in children, it is going to cause lower respiratory tract infection. In adults, it causes upper respiratory tract infection. Either ways, it is going to cause respiratory tract infections. That is common sense. Now, what I need to know is what is the meaning of the word syncytium, because please remember, microscopic examination shows you a syncytial appearance. Syncytium appearance means syncytium, like 10 people are studying together, they have made a syncytium. Group banana. Group banana means multinucleation. That is what you notice in respiratory syncytial virus. So the name is enough na. Respiratory, then we have rainy season. Respiratory causes respiratory tract infection. Syncytium matlab it's going to make a syncytium, and that is RSV for you. What is the last member of this family that we are left with? We are left with Nipah virus. I had told you a while ago that, after the 2018 outbreak of Kerala, this Nipah virus became very, very famous. Why? Because this had a mortality of almost 60 to 70%. Why were so many people dying? Because what part of the body does it affect? It affects the brain. It is causing encephalitis. So please remember, when we are talking about Nipah virus is very, very dangerous, or having a very high mortality. It is going to cause encephalitis as well as fever. And how will you identify the life cycle? It is going to be associated with fruit bats. So remember, the bat urine, that is the vector actually, right? The fruit bat is the vector, and the bat urine contaminating our food and water can get the infection to us, number one. So it can come via our food and water. Secondly, we also have pigs that can be involved in the life cycle. So please note, whenever you're talking about Nipah virus, first and foremost, you have to think of pigs. You have to think of pigs, which has to be there in the life cycle. Second, this can also be associated with patient secretions. These can also be associated with patient secretions. And apart from that, you have to learn the fruit bat, which is, so you see that fruit bat wala ek life cycle, you know that, okay, this is associated with Nipah virus. And if you read it opposite, in will remind you of what the patients have. Patients have encephalitis, which is very, very important. Very, very high mortality. There is a high mortality. That is why I had written Nipah separately. Everyone repeat with me. What will be there in the life cycle? Pigs will be there in the life cycle. Can it spread from patient secretions? Yes, it can. If I start reading it opposite, in pada, it is going to be known as encephalitis hota hai. What is the mortality? It has a very, very high mortality, 60 to 70%. And the only extra thing that you have to learn is going to be the fruit bat that is there in the life cycle. That is about Nipah virus, and that finishes off all of your Paramyxoviridae family. What do we come down to next? Next, we take up the Picornaviridae family. If I tell you the classification of Picornaviridae family, honestly, there are two groups, but you don't have to study all. So let us focus on the ones that you have to study under Picornaviridae. Number one, I can see there's a family of, see, देखो कैसे divide करा. Picornaviridae means either it is going to cause some intestinal fecal-oral wala, entero wala infection, or it is going to cause some inhalation wala infection. So inhalation means nose. Rhinovirus, common sense hai. This means rhinovirus is going to cause common cold. Very, very obvious. The only question that I expect on rhinovirus is what is the attachment receptor for rhinovirus, and the attachment is going to be with ICAM1. This is the only question for rhinovirus that we expect. It is going to come and attach to ICAM1. Rhinovirus ho gaya, khatam. Do you remember any parasite that attaches to ICAM1? So ICAM1, if a virus is asked, then which virus is going to attach to it? Rhinovirus will attach to it. If a parasite is asked, Plasmodium falciparum attaches to it. So rhinovirus story ho gaya. Enterovirus. So this will include polio, Coxsackie, of course, enteroviruses and ecoviruses. Out of this, you get a question on polio and Coxsackie, which everyone knows. Polio is something that you study a lot in medicine and in pediatrics, but I'll still give you a quick overview of what all is happening in polio over here. If I ask you what is the basic, matlab polio, jab final polio, you say a patient has polio, before I get into this entire life cycle, I think everyone knows that this is famous for having descending flaccid paralysis. That is the primary thing that polio causes, descending flaccid paralysis. But how many phases does polio go through? So whenever the polio virus is going to enter, so for example, there is some fecal-oral route by which the polio virus is going to enter, and if it has gone, matlab it's coming through the oropharynx, and after oropharynx, matlab it has to go to the GIT. If it has to go to the GIT, I will say this is the alimentary phase. So it's gonna go to the GIT. I can see it has gone into the intestine, and it can come out in the feces also. So that is the alimentary phase. But do you see that apart from this, a part of it has also gotten lodged somewhere near the tonsils. मतलब थोड़ा सा अगर oropharynx में है, थोड़ा सा intestine में है. So from there it will go on to the respective lymphatics. So from the oropharyngeal region, which lymphatics do you think it will go to? Of course, it will go to cervical lymph node. From intestine, which lymphatics will it go to? Obviously, it will go to mesenteric lymph nodes. So ma'am, when it has gone into these lymph nodes, call it the lymphatic phase. Now, the next phase into which it enters is the lymphatic phase. From the lymphatics, now it's going to go in, every time lymphatics drain into the blood. So from the lymphatics, it's going to drain into the blood. Something, virus going into blood means now I call it viremic stage. Once it goes into the blood, I'm going to call it viremic stage. And from there, obviously, it is going to go to the different parts of the spinal cord, that is the neural phase. And that is when the patient develops descending flaccid paralysis. Repeating, first it goes into the gut, so alimentary phase. From there it goes into lymph nodes, so lymphatic phase. Lymphatics always go to blood, so viremic stage. And from viremia, it goes into the different parts of the spinal cord and the motor neurons, so that results in paralysis. What sample do you think you're going to take? Ma'am, you will say, ma'am, I want to find out because polio has been eradicated and all these things that are being said. So in the community, first I want to find out that is there a risk still present? So I think what you should be doing for that is take a sewage sample. Why do I take a sewage sample? Because I just realized that polio is going to get excreted in the feces also. So sewage sample to lena padega, that is one thing. But if I have a clinical patient of polio, so sewage sample you're taking just to know the burden in the society, right? But if I have a patient of polio, the sample that can be taken again, ma'am, from the patient also. Right now you are saying that it is going to come out into the feces, so take a feces sample. Ma'am, you also said that it's going to go somewhere in the oropharynx, so you can also take a throat swab. These are the kind of swab, either a throat swab or a rectal swab can be taken, but the isolation is very, very rare, as they say, right? So this is what you do. For knowing the epidemiological burden, you take sewage samples. For taking patients, you take throat or rectal swabs. Now, this was about polio. Do you remember, other than polio, what is the other one that I told you we'll be studying? We'll be studying Coxsackie. How many types of Coxsackie do you know of? We know of Coxsackie A as well as Coxsackie B. And I can see Coxsackie has a lot of serotypes. Coxsackie A has a lot of serotypes like 1 to 24. Coxsackie B also has 1 to 6. So, kaise yaad kare? What is common between them? Both of them cause hand, foot, mouth disease. Very simple. There will be lesions on the hand and the feet and the mouth. Hand, foot, mouth disease is caused by both. So Coxsackie A is going to cause H, H and H. What is H, H and H? Number 1, it causes herpangina. Number 2, it causes hand, foot, mouth disease. And number 3, it causes acute hemorrhagic conjunctivitis. Acute hemorrhagic conjunctivitis. They ask you this question. Don't take this question lightly. Acute hemorrhagic conjunctivitis is caused by Coxsackie A, okay, but they ask you which Coxsackie A. So, jo last wala hai, that is Coxsackie A24, which is also known as enterovirus 70, because do you remember, right now I told you, Coxsackie is actually an enterovirus. So, which enterovirus can it be? Enterovirus 70 is very, very important. That is what is Coxsackie A24, and this causes acute hemorrhagic conjunctivitis. Repeating, Coxsackie A causes herpangina, causes hand-foot-mouth disease, causes acute hemorrhagic conjunctivitis. Whereas Coxsackie B, hand-foot-mouth disease to hai hi, but with B, you will start making a list. And it causes something called as the Bornholm disease. Bornholm disease, एक C छोटा सा लिखो, that I'll come to later. Bornholm disease is also known as devil's grip. It is also known as dynia, pleurodynia, and it is also known as epidemic myalgia. Only important for INI-CET students. Repeating, Coxsackie B causes Bornholm's disease, known as devil's grip, known as pleurodynia, known as epidemic myalgia. That is what Coxsackie B causes. And what is this tiny little C over here? It can also cause cardiac involvement, that is carditis. So please note, these are the differences. But if you say, ma'am, last day, and for FMG students especially, if you ask me, ma'am, what is that one thing in this table that I have to learn? I will say, learn acute hemorrhagic conjunctivitis is caused by Coxsackie A24. That is what you learn. Okay, done with this. We are done with the entire Picornaviridae family, right? Picornaviridae is done. So now I can move on to the next family, and that is the Rhabdoviridae family. What do I need to know under Rhabdoviridae? Actually, we have two things under it. One is the Lissa virus, one is vesiculovirus. This is not very important. The vesiculovirus causing vesicular stomatitis virus, it's actually an arthropod-borne infection, not important. But Lissa virus causing rabies, again in medicine, is very important. But I'll pick up the most important parts of rabies that you have to know, especially the pathogenesis and the diagnosis is important. So let's get going. So rabies mein, I've got you a tiny little diagram over here with a dog, and you know this is associated with a dog bite. You just need to help me with fill in the blanks of whatever I have written over here. So first and foremost, if this, for example, is a dog and the dog has bitten a person in the lower limb, so where is the virus going to multiply? Ma'am, jo bite hoga, that is going to lodge the virus in the muscle. Okay, once it goes into the muscle, can you tell me which is the receptor to which it is going to bind? Yes, which receptor will it bind to? Acetylcholine receptor. It is going to bind to acetylcholine receptor. And in which direction is it going to travel? You will say, ma'am, it's going from the lower limb and it's going ulta. It's going ulta backward towards the spinal cord. So this is a retrograde transport. This is a kind of, after binding to acetylcholine receptors, this is going to be a retrograde transport that will occur. Means from the legs you are going towards the trunk. Means you are traveling what? You are traveling centripetally. You are spreading centripetally from the legs towards the center. Centripetally, where is it going to reach? It reaches the spinal cord. Which ganglia of the spinal cord does it reach? It reaches the dorsal root ganglia of the spinal cord. And why has it reached the spinal cord? cord over here? Because it has to ultimately go to the brain. So of course it is going to reach the brain. In the brain, we of course know that it is going to result in the formation of these Negri bodies. Which part of the brain does have Negri bodies? There are two parts. One is hippocampus and the other is the cerebellum. This is where the Negri bodies are going to be seen. Tell me one more question. अब Negri bodies brain में होता है. Brain तो of course autopsy के time ही you will see, right? Is there any stain for the Negri bodies? Number one, Negri bodies are seen in cerebellum, hippocampus. Number two, Negri bodies are going to be stained by what stain? There is a stain by the name of the cellar stain that you have to know. So Negri bodies, cellar stain. ठीक है. After it has reached the brain, now it will start moving out. It will start spreading to different parts of the body. मतलब outward movement मतलब it is going to spread centrifugally. It is going to spread centrifugally to what all parts can you see over here? Ma'am, I can see it has gone to the cornea, that is the eyes. I can see it has gone to different glands. I can see it has gone to the nerves. It can also go to the skin and the hair follicles. Yes. So it can go to all these parts, guys. It can go to all these parts. That is, it can go to the eyes, the salivary gland, it can go to the skin. That is why after a while, if I will ask you that how do you want to do the diagnosis, you will say that for doing the diagnosis, the best specimen that we can take is the hair follicle at the nape of the neck. At the nape of the neck, the hair follicle is the best specimen. And how do you do antigen detection? By direct immunofluorescence, DIF. So remember, based on this, why? Because pehle to virus brain tak gaya. After going to the brain, it has gone to cornea, it has gone to salivary gland, it has gone to the skin. So from the skin, you can take a sample, hair follicle at the nape of the neck. All of this is said and done. So let me repeat. First and foremost, the dog was biting in the muscle. Which receptor was it binding to? Acetylcholine. Which direction is it getting transported? Ma'am, ulta ja raha hai. It's going in a retrograde manner. And where is it reaching? Dorsal root ganglia of the spinal cord. After that, it is going to the brain. From the brain, it is spreading outward to the eyes, salivary gland and the skin. At what rate is this happening? Anyone who can tell me that? Spread of rabies virus progresses in axon at the speed of 3 mm per hour. This is just general. अब this they have calculated from the lower limb. यहाँ से अगर देखो तो it will take 3 mm per hour to go. But imagine, for example, it was taking say for example few hours, 10 hours or 12 hours or 20 hours. But if a person is very short-heighted, don't you feel that if a person is short-heighted or if the bite occurred on the upper limb, the timing to reach the brain is lesser. From the lower limb reaching the brain is too much. From the upper limb reaching the brain is lesser, right? So for the upper limb, the timing spread time will be shorter. In children are small heighted, so in them the spread time will be shorter. So remember, for children, short heighted people and upper limb bites, the speed or the progress is going to be easier, or you can say it's faster for the virus to move up because it's not going to have so much of distance to travel. But yeah, this is a question. The speed is 3 mm per hour. On that note, definitely the Rhabdoviridae family comes to an end. So let's begin with the arboviruses. And what do we know under it? The name itself is explanatory. So if you look into it, it is an arthropod bone virus. So some kind of vector is going to be involved over here. So let me tell you a quick overview of what all viruses come under it. Bunya virus, Toga virus, Flaviviridae, Reoviridae as well as Rhabdoviridae. Have you already studied Rhabdoviridae somewhere else? Rabies. Rabies is not arthropod bone. You know rabies is because of dog bite and animal bites. But there was a part of the rabies viridae family known as vesicular stomatitis virus, that is arthropod bone. Similarly, I'll be teaching you in a while what is Reoviridae. Reoviridae is nothing but rotavirus. Rotavirus is diarrhea wala virus, that is not arthropod bone. But there's another member in the family known as Colorado tick fever. Tick is definitely arthropod bone. So some viruses of these families are put in over here. Then comes Bunya virus. Then comes Toga virus. Toga has always reminded me of, do you guys remember? I'm sure all of you have seen a Tonga car. Tonga car has a horse on the front and a cart on the back. You can quickly go through this. Yes, so what exactly is a Tonga car? So Tonga will definitely remind me of Toga virus. And car, I first and foremost know Tonga is going to have a horse. So all the horse related diseases are going to be here. So equine, eastern equine encephalitis, western equine encephalitis, and other than the horse, we have C, And we have R. What is C and R? So that is going to be chikungunya and rubella. So repeating, Tonga car will remind me of horses. So all the equine encephalitis, chikungunya and rubella. But now I hope you know the rubella has been reclassified into which family. I've told you so many times in this rapid review. It is now a part of the Maternaviridae family. Okay, other than that, we now have another virus family called flavivirus, and this is what you have to study in maximum detail. You have Japanese encephalitis, yellow fever, Zika, dengue, then we have West Nile fever, even hepatitis C virus comes under flaviviridae. Go back to your hepatitis chapter. Remember, private hospitals favor rich clients, favor flaviviridae. Flaviviridae was hepatitis C. So now let us know the ones which we have to know in a little bit more detail. What am I going to teach you? I'm going to start. See, rubella हमने already कर लिया. Equine you need to know कि horse related है and encephalitis है. That is more than enough. What you need to know is chikungunya to begin with. But do you want to do one more summary table and know which of them are what kind of arthropod? Aedes है या फिर Culex है? Should we make a list? Okay, let us start. Let us make a list of all the ones that are transmitted by Aedes. So how are you going to learn? You are going to write Aedes cried, Aedes mosquito cried. So when you write Aedes, I have emphasized on some alphabets. Aedes, so E's, Eastern equine encephalitis. Eastern equine encephalitis. Z, Aedes will remind me of Z for Zika virus. Then we have C for California encephalitis, C for chikungunya, R for Rift Valley fever, Y and D, I think everyone knows, yellow fever and dengue fever are transmitted by Aedes. So repeating once again, when you write Aedes, Eastern equine encephalitis, Zika virus, California encephalitis, then you have chikungunya, Rift Valley fever, yellow fever, dengue fever. These are all associated with Aedes. Whereas what is associated with Culex? So remember, Culex I have learnt as cute, and we have learnt Japanese and Western females are cute. Okay, so what is Japanese and Western females are cute? So Japanese, of course, will be Japanese encephalitis. Western, of course, will be West Nile fever. So these are quite simple. And finally, females say you are going to learn F for filariasis, Buscheraria bancroft. These are all transmitted by cute for Culex. So remember once again, that's quite an interesting mnemonic. So Japanese encephalitis, West Nile fever, and then you have females के साथ filariasis and cute for Culex. So you know what are the ones by Aedes, you know which are the ones by Culex. Now you're going to go ahead and also learn all of their incubation periods in one go. So when I talk about incubation period, if you look at dengue is something which has 5-6 alphabets, so incubation period is 5 to 6 days. Chikungunya pura to dekho hardly anyone says. We always say there is chick fever or chikun has happened. So chikun also, if you say, it has approximately 5-6 alphabets, so there are 5-6 days incubation period. Now when I talk about the yellow fever, so yellow also, if you read, has approximately 6 alphabets. So again, 3 to 6 or 5 to 6 days is the incubation period. Kaisanur forest disease. So if you write Kaisanur forest disease, can I write it as Kaisanur forest disease? Because forest disease will tell me that the incubation period is 4 to 8 days, right? And finally, the Japanese encephalitis, which is the longest name, Japanese encephalitis, 5 to 15 days. Let's do a recap of this because I know you liked the mnemonic, but you need to revise it once. All the things with 5-6 alphabets like dengue fever, like chikun, like yellow fever, all of these are 5-6, 5-6, 5-6 days. Kaisanur forest disease is going to be 4 to 8 days and Japanese encephalitis is 5 to 15 days. So the vectors are done, the incubation periods are done. Now we can start off with the one that we have to know in detail. Chikungunya, nothing very fancy about it. I think you already know that Aedes is the vector that you've studied. Aedes cried, chikungunya. Number one, you know that this is not just fever, but there is joint involvement. Joint pain and joint involvement happens in chikungunya. Apart from that, in dermatology, you are asked about this chick sign. What is chick sign? Can we all see the hyperpigmentation over here? So देखो ये तो simple है ना, that chick sign will be seen in chikungunya. This question no one will ask you. This you already know. They will ask you what is the chick sign. So chick sign is nothing but the hyperpigmentation that can be seen usually around the nose after chikungunya recovery. So please remember hyperpigmentation post chikungunya, that is the chick sign. So chikungunya is done. Now let's go on to the Flaviviridae family. Under this, the first one that I'll want to teach you is Japanese encephalitis. I've tried to make one flashcard for Japanese encephalitis. So what all do you see over here? Number one, I can see a mosquito, and I know the mnemonic Japanese and Western females are cute. So which mosquito must this be? This must be Culex. So now one way I see a Culex, and over here I see some cycle happening with a bird. So Culex bird wala cycle is happening. And over here I see a pig, so I have a cycle of Culex pig also happening over here. So what are these transmission cycles? Let's quickly go through it. So please note, over here I can notice, please note over here, there is the vector which is Culex. Kaunsa wala Culex? Culex tritinio-rhynchus. All over the world, tritinio-rhynchus. But in India, Culex vishnui. Vishnuji always reminds you of Hindu mythology, so Vishnuji with India. Okay, so Culex vishnui is common in India, and Culex tritinio-rhynchus is all over the world. I have a Culex over here, fine. Apart from that, I see these birds. You know what are these birds? These are the reservoirs. They are known as the RD'd birds. This is the natural cycle that happens. But if you have to amplify, so dekho, amplification ke liye pigs are going to be there. So this cycle that is happening over here is the amplification cycle between the pigs and the Culex. So simple. If they have mentioned the Culex and the birds wala cycle, that is the natural cycle. Culex and pig wala cycle, that is the amplification cycle. That is Japanese encephalitis life cycle. What is the question that is asked? Encephalitis, the word is telling me that okay, patient will have encephalitis. But what is the vaccine that they ask you? There is SA-14-14-2 vaccine, which is a live attenuated vaccine, which is most commonly used in India. So SA-14-14-2 yaad rakhna hai. Other than that, there is an inactivated vaccine known as Nakayama and Beijing strain. Nakayama and Beijing sounds like Japanese words. So Nakayama and Beijing strains are also used as an inactivated vaccine for Japanese. I hope you are not confusing it with the Nagayama spots. Guys, where did we study the Nagayama spots? If you remember, Nagayama spots were a part of that sixth disease, Roseola infantum, HHV6, human herpes virus 6. That is what had Nagayama spots. What I'm saying over here is Nakayama. Nakayama and Beijing strain is for Japanese encephalitis. So Japanese encephalitis, tick mark. Next, what we come down to is going to be yellow fever. So what is it about yellow fever? If I ask you what is the vector, you will say, ma'am, you had a mnemonic where you said Aedes cried. Cried may obviously we had picked up yellow fever also. So the Aedes aegypti is the vector. What is so yellow about it? Yellow matlab it is causing jaundice, and if it is causing jaundice, this means there is a hepatic involvement. That is only when something can cause jaundice, right? So hepatic involvement will occur. So how will I do the diagnosis of this? Number one, you can do the antibody testing, means IgM antibody will be detected in the early course of the disease, and IgG antibody will be detected in the late course of the disease. So one is antibody detection, but this you will tell me. What is the cytopathic effect? Cytopathic effect means what bodies are seen. Cytopathic effect, can you remember yellow fever? I have taught you this under general virology. So I had taught you that yellow fever may we are going to have Tories bodies. Yellow fever is going to have Tories bodies, and that is what you need to remember. Very, very important point about yellow fever. But now tell me, yellow fever is endemic to some countries, and in India, yellow fever does not exist. So imagine someone traveling from Africa or America where yellow fever exists, and that person is coming into our country doesn't have yellow fever. So there is a risk that we and our population can get it. So how do we maintain the fact that we have to remain yellow fever free? So the India status is that we are free from yellow fever. Why? Because we have made a rule that anyone who is traveling from an endemic zone has to be vaccinated. Number one, it is essential that a person is vaccinated. The vaccination certificate leke aao. If the person is unvaccinated, we make sure that the quarantine of 6 days is maintained. Why 6 days? Because yellow has how many alphabets? It has 6 alphabets. Remember, the incubation period was 3 to 6 days, which means that if someone has to have yellow fever, he will start manifesting it maximally by the 6th day. So we make sure we isolate and we quarantine a person for 6 days only if he or she is unvaccinated. Also, because we know that yellow fever has a vector that is Aedes aegypti, so we will make sure that the Aedes aegypti index is less than 1 around all the airports, the seaports, and the routes of entry into our country. We've made sure that the Aedes aegypti index is less than 1. That is how we have managed to keep ourselves free from yellow fever. But now you said that acha ek vaccine hota hai. So obviously there will be a question on vaccine. Which vaccine is there? There is a vaccine called the 17D vaccine. PSM question. 17D vaccine is a live attenuated vaccine. Live attenuated will always mean that you cannot give it in immunocompromised people. This is going to be contraindicated in immunocompromised individuals. Second, this vaccine is prepared from allantoic cavity. Allantoic cavity means egg. Vaccine is being prepared in an egg. It has an element of an egg. So can I say it is contraindicated in all the people who are going to have an egg allergy? That makes sense. So 17D vaccine, live attenuated, prepared from allantoic cavity. Do not give in immunocompromised people. Do not give in people with egg allergy. And please remember that once, like today, if someone gets vaccinated, when will he get his certificate? The certificate will be given within 10 days. And what is the validity of that certificate? Earlier, they used to say 35 years or so, but now the validity is said to be lifelong. So remember, within 10 days it is issued and it is lifelong. That is why I said someone comes to you with a vaccine, you let him into your country. Someone does not come with a vaccine, then you have to quarantine for 6 days. That is all about the very famous, yes, yellow fever. Let's move on to another disease. The other disease that we have is the famous monkey fever or Kaisanur forest disease. And I think I've already told you that with forest disease, you know that the incubation period is going to be 4 to 8 days. Kaisanur forest disease, what is this life cycle showing you? I can see a hard tick as the vector. So yes, there is going to be a hard tick. And I can see monkey as the amplifier host. No wonder it is called monkey fever. Monkey fever will have monkey as the amplifier host. It is going to have a hard tick, and can you see the hard tick is such that it is transferring it via eggs to its progeny also. The tick is also giving it like inheritance, like property. He is giving the virus further and further to his children also. So it's constantly going on in the tick cycle. It can involve or cause amplification in the animals also, especially monkey. And then the transmission is going to occur. Can you see? Either we come in contact, we all can notice, either we come in contact with one of the animals, or there is a possibility that there can be a tick bite also. Both of them are possibilities that you have. So number one, there is a tick bite ka possibility. There is coming in contact with the animal, that is the possibility. But is there a person to person thing? Nahin. We made it very clear in the beginning कि forest wala disease है, forest से ही आएगा. Either it will come from a tick or it will come from a monkey. It's not gonna come as human to human. So there is no person to person transmission that is going to occur. So yes, on that note, monkey fever is done. We move on to the next one, and that is a previous year exam question, that is the Zika virus. Now we all know Aedes cried, so we know the vector over here is the Aedes mosquito. We can see the Aedes mosquito over here, and that is the vector. So a human being has definitely got it, but what are the routes other than Aedes? How does it transmit? I can see mother to child transmission over here. I can see sexual relationships also resulting in transmission, and I can see blood transfusion also happening that can result in transmission. So Zika virus can transmit from mother to child via close contact as well as via blood transfusion. But there was a question, especially mother to child se related, they ask you questions. What happens in the mother and then what happens in the child? Both clinical spectrums of Zika virus you have to know. So in the mother, I can see the heart is definitely pointed here. So cardiac abnormalities hoga. Then I can see the muscle is pointed out over here and the joints are pointed. So muscle pain hoga, joint pain hoga. There is myalgia, there is arthralgia. I can see there is an element of rash mentioned over here. So rash will be there. And finally, these patients can also have Guillain-Barré syndrome. So repeating once again, cardiovascular problem, myalgia, arthralgia, maculopapular rash, and GBS can occur. Now moving forward, when it transmits into the placenta and it goes into the child, firstly, which cells of the placenta are going to keep it? Previous year AIIMS exam question, and that is the Hofbauer cells. I hope you remember from pathology Hofbauer cells are nothing but the macrophages of the placenta. That is how it's going to go and sit over there, and from there it will go into the child. So what all can it cause in the child? It can cause a lot of optic, or you can say the ophthal anomalies can occur, like optic neuropathy and congenital glaucoma can be there. And in terms of the skull abnormality, microcephaly has been noted. So eye problems and skull problems, that is what we have with Zika virus. So Zika is also settled. Now the next one, which I believe everyone is anyway aware of, and that is the dengue fever. And dengue fever, of course, the vector is going to be Aedes. Dengue fever ke liye kitna serotypes hai? We have 4 serotypes, that is DEN 1 to DEN 4, out of which DEN 2 is definitely the most dangerous one. So DEN 2 is going to be very, very dangerous. So 4 serotypes are there, but in Bangkok now a 5th serotype has been reported, and that is DEN 5. So I'm sure all of you know that dengue fever is characterized by a decrease in the platelet count. So what are you going to do? We are always going to go in for platelet transfusions. But is that the only thing that is altered in the blood? No. There can also be an increase in the hematocrit. Basically, these patients are going to suffer from hemoconcentration. The plasma loss, the water of the blood is going to get lost. So when there is plasma loss, the blood becomes very, very concentrated. Means the hematocrit will increase. Means you have a patient of dengue, and what are the 2 things that you have to follow up? Number 1, you have to follow up the platelet count. Number 2, you have to follow up the hematocrit. So the platelet count will fall and the hematocrit will increase. That means you are going severe and severe. So how do you think you're going to diagnose it? Of course, we are going to diagnose it by antigen testing. Antigen ka kya naam hai? NS1 antigen. See, let me tell you, there are 2 antigens which are their all-time favorite antigens. One is an NS1 antigen. Of course, you know this is going to be for dengue fever. One is an RK39 antigen, which we know is for Kala Azar or Leishmania. So these 2 antigens in our country are the most frequently studied antigens because the predominance of these diseases is much. So remember, NS1 antigen testing karte hain. Of course, you can do antibody testing also. Antibody testing is done for IgM using something known as MAC ELISA, but then nothing can beat genetics. Although for dengue, honestly, you don't need genetics because antigen antibody is good enough to make the diagnosis, but I had to copy paste PCR everywhere and I have done that. I hope everyone's okay with this because all your arthropod-borne infections are sorted. I'm going to move on to some miscellaneous things that are left here and there, and that is the Rioviridae family. I just told you that the Rioviridae family had something called Colorado tick fever, which was the arthropod-borne. But I'm not talking about the arthropod-borne one. I'm talking about the other member of the family, and that is rotavirus. And I think everything about rotavirus I have already discussed with you guys. I'll quickly repeat it. What do you need to know about rotavirus? Rotavirus causes, number 1, I'll write it again. I told you it is like a rotating wheel. So if someone asks you what is the shape of this virus for the diagnosis, the shape of this virus is going to be a, or just not rotating wheel, just learn it as a wheel. The shape of this virus is going to be a wheel. And why did I say rota? Because there is a rota hua bachcha. Why rota hua bachcha? Because that kid is having diarrhea. This is the most common cause of diarrhea in children. So it is a rota hua bachcha. Diarrhea hoga. Rota hua bachcha mein diarrhea hoga. So this is the only double-stranded RNA virus. The only double-stranded RNA virus. All these points I have taught you in your general virology. So please note, the diarrhea wala kid is gonna be the double-stranded RNA virus. Rota hua. Why rota? Because he's actually having diarrhea. And rotating wheel will tell you the shape. Now, someone's having diarrhea. How do you think there's going to be transmission? The transmission is going to be feco-oral. And what do you think is going to be the toxin? Something to do with the intestine, enterotoxin. The name of that toxin is NSP4. So NSP4 is an enterotoxin, and that causes this disease. How do you think you're going to do the diagnosis? Ma'am, diarrhea ka case hai, to stool sample is what you'll take. Antigen detection karoge, that is also settled, and you will do PCR. Common sense diagnosis is there, nothing fancy. But vaccine questions aata hai, that comes in pediatrics. What are the vaccines for rotavirus that you have to consider? There is Rotatech, there is Rotarix, Rota se to I will learn. These are the rotavirus vaccines. But is there any side effect of these vaccines that they ask you? Think from pediatrics. What is the side effect? Intussusception is a very famous question that you get. See, intussusception is, as it is a very famous topic in pediatrics, but because I teach you path and micro, let me tell you 2 intussusception questions questions which will always haunt you somewhere or the other. So related to intussusception, the question that you get, so I'll write intussusception over here. Related to intussusception, number one question that you get in microbiology, it is a side effect of the rotavirus vaccine. And in pathology, do you know which question do you get? One polyp can cause intussusception. This is associated with Peutz-Jeghers polyp. PJP, Peutz-Jeghers polyps, can also cause intussusception. These are the two integrated questions of path and micro for intussusception that you will integrate with pediatrics and medicine. Okay, so this is also done. Reoviridae family ho gaya. Now we come down to Filoviridae family or the filovirus. So filovirus mein what are we going to have? We are going to have something called the Marburg virus. Marburg virus causes a lot of hemorrhage and fever. So it is going to be the hemorrhagic fever. Not many questions come on it. But one question of Ebola virus which came up in Africa is very essential. What do you already know about Ebola virus? Ebola virus looks filamentous like this. Or I had learned that Ebola virus is going to be like a bowl of spaghetti pasta. It is like a bowl of spaghetti pasta. So in other words, it is going to be filamentous in nature. How is it going to spread? The spread of Ebola virus is going to be by secretion and contact. So let me just show you a life cycle first. In the life cycle, I can see a bat because I realize that bat is going to be the reservoir host. I will see a bat over here. Dekho, dhyan rakhna. Have I taught you in the same segment of virology bat somewhere else? I had taught you fruit bat. Fruit bat was for Nipah virus. This is just a bat. Along with the bat, I can see that the wild animals are also affected, and that is how it's coming to humans. So how is it coming to the humans? Either we have come in contact with a bat or we have come in contact with some wild animals. So number one, we can either come in contact with a bat or we can come in contact with a wild animal, but human to human transmission over here is known. Human to human transmission is also known for Ebola virus. That is why Ebola virus is being said to be so deadly, because even from patient to patient, that is why I said, how is the transmission occurring? It is occurring by secretions and contact. So patient to patient is also there. Where did you not have any patient to patient? Remember, Kaisanur forest disease, wo sirf forest se aayega, either from a tick or it was coming from the monkey fever, but it was not human to human. Here, it can come from a bat, it can come from the monkey, or any wild animal, but it can also come from human to human. That is Ebola virus. Now, Ebola has a lot of strains. So remember, the Zaire Ebola, Ivory Coast and Reston. So please note that Zaire Ebola is most virulent. So Zaire Ebola is going to be very, very virulent. Ivory Coast is the least virulent, and Reston is resting variant. वो rest कर रहा है. That is not causing any disease. Reston is not going to cause any disease. If you can learn the incubation period, it is between 3 to 15 days. Not very important, I would say. But this is important. The Zaire is going to be very, very deadly. ठीक है? So I have learned Zaire is zabardast. It is going to cause maximum virulence. And Reston is resting. It is not going to cause any disease in humans. If I tell you the latest medicine questions of Ebola virus, please note that Ebola ke liye there is actually a monoclonal antibody that has come up or a drug that has come up, and that is what you need to know for Ebola, and that is Inmazeb. Inmazeb is actually a trio of monoclonal antibodies that you have, even if you don't know the names of these, but yeah, Inmazeb is the drug name. 3 monoclonal antibodies which is being used for the treatment, and also we have a vaccine now, and that vaccine comes before obviously the most zabardast wala virus strain, that is the Zaire vaccine. Yeah, so there's a vaccine also that has been developed. I hope everyone's okay. We finished off all the arboviruses, alongside which we have also finished off all the very, very important different miscellaneous filovirus, reovirus, that is settled. Now we are just left with 2 viruses. One is going to be the retrovirus, matlab HIV, and the other one is going to be the coronavirus. So let's get going. Now we talk about retrovirus. Actually, we always learn retrovirus as HIV, but HIV actually, apart from that, there's another retrovirus called HTLV. Although I have taught you HTLV in pathology fully, I will give you quick salient features here. But pehle let me talk about the most important one, and that is HIV. Now, when I talk about HIV, please note, if I ask you, what is in terms of India mein sabse common, abroad mein sabse common, so please note, when we are talking about HIV, it is HIV-1 that is going to be very, very important. It is going to be group M, and it is going to be the serotype C, which is very, very common in India. It is the serotype C, which is very, very common in India. So remember, HIV-1 group M serotype C is the one that we encounter most commonly in our country. But of course, we encounter HIV-2 also. So whenever you say that, ma'am, HIV ka test ho raha hai, we test for HIV-1 and HIV-2. Okay, the testing is for both, but HIV-1 is more common. And ratlo, group M serotype C is common in our country. Now for HIV, we always know the structure of this virus is very, very important. If you go very carefully, these are all the structural genes, right? So the structural genes tells me that there is, first I'll highlight the genes. There is a GAG gene, there is a Pol gene, and then there is an envelope protein. Let me start with envelope. Envelope has GP, envelope ka pura naam hai GP160. 160 I have divided into GP120, and instead of exact 40, 41, okay? So GP120, which is the one that you see coming on the surface, and GP41, which you see going through the membrane, right? So 120 is going to be the surface wala, and 41 is going to be the transmembrane one. That makes up GP160. Now when we talk about the GAG gene, if you look at GAG gene, I will write P6, P7, then 17, then 24. How do you learn it? 6, 7, 17, 24. Repeat with me. 6, 7, 17 and 24, out of which P24 testing is very, very important. Whenever you get questions on needle stick injury, kya testing karoge? P24 testing karenge. That is what I'll come to you in a while. These all come under GAG. You don't have to learn which one is present where. You just need to know P6, 7, 17 and 24. Coming to the Pol. So Pol mein you will learn RIP. There are 3 RIP enzymes. R for reverse transcriptase, which you need to know is RIP at the age of what? Reverse transcriptase, RIP at the age of 66, okay? I is going to stand for integrase and P is going to stand for protease. You don't have to learn their P values. Repeating once again, reverse transcriptase, integrase and protease, out of which reverse transcriptase RIP kaun se age mein hua? 66 pe hua. So these are all the structural proteins. I'm repeating once again. The envelope has GP160. 160 is divided into 2 parts. There is 120 and 41. GAG has 4 things, 6, 7, 17 and 24. Coming to Pol, Pol has 3 enzymes, that is RIP. Now let's see if this HIV enters into our body, how will it attach and where will it attach? Either it can attach to the CD4 T cells or it can attach to the macrophages. So now you think, ma'am, attachment to common sense hai. It is this GP120 and 41 that will come and attach. वो surface पर है, so that is what will come and attach. Exactly. So for the attachment, we have GP120 and GP41 that will be used, but single attachment does not work. You will realize, other than that, there is also a co-binding. Something else also binds. And what does it come and bind to? It's just not going to bind to the CD4 T cells. No, it is also going to bind to something called CXCR4 and CCR5. ये क्या लग रहा है? Have you read about it? Try to think. CXC, CC. Yes, ma'am, I have read this somewhere, but in pathology, these are chemokine receptors. So basically, I realize that for the HIV to bind, only single just going and sitting on a CD4 T cell will not work. सिर्फ ऐसे CD4 पे जाके बैठ जाओ, that is not going to happen. It will need to do some extra effort, and that is it will have to bind to the chemokine receptors also, that is CXCR4 and CCR5. So now let's imagine that this is come into the system. Now finally the binding is complete, fusion will occur and the virus is going to enter us. If the virus enters us, what is going to be the entire timeline that we are going to consider over here? So first and foremost, if you look on the y-axis, we have the CD4 count. Normal CD4 count is much above 1000, around 1500 or so. So starting में तो the CD4 count is going to be over there. But ma'am, starting में the virus is going to be, initially the virus is going to of course be 0. So you have 2 graphs going on over here. This graph is telling you, the blue color graph is basically telling you about the CD4 count. Whereas this red color graph is going to tell you about the HIV virus. So starting में virus तो 0 है and CD4 count अपना 1500 के आसपास, very very good. In the initial infection, what you call as acute HIV syndrome, where patient will have fever, muscle ache, myalgia, arthralgia, lymphadenopathy, basic fever wala symptoms, I realized that gradually the CD4's count has started going down, right? Why? Because the HIV virus has started coming up. So HIV virus body में multiply कर रहा है. The HIV is multiplying in the body. That is why the CD4 count is going down. That is what happens in the acute HIV syndrome. After that, I realized suddenly the virus has started decreasing and my CD4 count has started improving. Why? Because your body is trying to fight. ऐसे थोड़ी that some virus will come and you will not do anything. Your body is trying to fight. So your CD4 count starts improving and the virus amount starts going down and the patient suddenly becomes free of symptoms or totally fine. Clinical latency. Remember, clinically patient is looking fine, but if you do test for microbiology HIV testing, that is not latent. There is no microbiology latency that is noted. Matlab the testing done at this phase will still come out to be positive. It is only a clinical latency, not a microbiological latency. Okay, after that, once this phase is over, and this phase can go on for even up till 10 years, then comes a phase of constitutional symptoms, and then the patient is going to have opportunistic infections. So now the next question that comes is, which is going to be quite a deadly table, and I'm sorry for it, but what are the opportunistic infections that you have to know for HIV? The opportunistic infection is going to depend on the CD4 count. So see, there is no end of learning this table, but at least I can tell you what are the most expected questions. Less than 500 mein what they have to ask you is going to be tuberculosis. Must know question. Less than 200 mein what they are definitely going to ask you is pneumocystis jirovecii pneumonia, their favorite question of path medicine micro. Less than 200. In less than 100, they have to ask you about the cerebral toxoplasmosis, cryptococcal meningitis, cryptosporidiosis, even CMV can be seen. So, sorry, CCC things are coming. What did I say? Cerebral toxoplasmosis, cryptococcal meningitis, cryptosporidiosis, and CMV can also be there. But please remember, less than 50. Less than 50, CMV, chorioretinitis and MAC infections are the most common. Repeating, less than 50, CMV, chorioretinitis and MAC infection. So repeating, TB. So if I want you to focus on the lungs wala finding. Less than 500 mein TB hoga. Less than 200, so very, very important, there is going to be pneumocystis jirovecii. Less than 100, all the CCC things are there. CMV, retinitis and MAC infections are going to be less than 50. In fact, if I try to note all the lung related things, you'll say, ma'am, lung mein pneumonia kyun hoga? Either there's a TB wala problem, or there's a streptococcus pneumonia, pneumococcus wala problem, or there's a pneumocystis carinii pneumonia. These are the three problems. Either it's a bacteria that is TB, or it is a bacteria that is streptococcus pneumoniae, or it is a fungus that is pneumocystis carinii. So I just told you that TB will occur at CD4 count less than 500. Even streptococcus pneumonia occurs at a CD4 count less than 500. So bacterial infections under 500 hota hai, but pneumocystis carinii is going to occur at a CD4 count less than 200. So first thing that you look out in the paper is the CD4 count. Then you will see what is the radiology given. We all know streptococcus pneumonia, jo pneumonia hota hai, that involves an entire lobe, that is lobar consolidation. For TB, I think everyone knows there's a very famous snowstorm or hazy appearance in radiology. And pneumocystis carinii is very famous for perihilar. Around the hilum, there is involvement seen. Repeating, pneumonia mein to lobe involvement, TB mein snowstorm, hazy pattern, and pneumocystis perihilar opacities. You will say, ma'am, if I have to make my decision on the basis of CD4 count and the radiology, what is a more likely thing on which I'll make my decision? For example, they say that the CD4 count is say 200. You will say, acha, 200 se kam ja raha hai. I think it is pneumocystis carinii pneumonia. But they say along with that, there is a lobar consolidation. You will say, oh, radiology has to be given more importance. What you're seeing in the patient versus what you're just going by numbers. Obviously, ma'am, what I'm seeing in the patient carries more significance. So give radiology anytime more significance over the CD4 count. Repeating, less than 500 में bacteria सोचना, less than 200 में think of pneumocystis carinii pneumonia. So going ahead with the lab diagnosis, I want to tell you what is the screening methodology, and you don't have to learn all these ELISAs, but out of all these enzyme immunoassays or ELISA, at present, it's the 4th generation assay which is said to be the most important screening methodology that we have. Whereas for confirmation, I think everyone is aware that for confirmation, we have the Western blot testing that is there. I know a lot of you have a confusion कि ma'am, for this confirmation, ये जो Western blot करते हैं. So see, I've got you a list of everything. ELISAs are of 5 generations now, but as per all the guidelines, the 4th generation ELISA is going to be our screening test. And as per the confirmation, Western blot is the screening test. So the last thing that you have to know कि Western blot होता क्या है? This is how a Western blot strip looks like. And in this Western blot strip, I realized that there are a lot of GP molecules that are written. Achha, so basically all the HIV GP molecules are being tested over here. Wherever the band will come, वो मतलब positive है. So how many bands should come for me to say that HIV is positive or not? So one definition has been given by WHO, one definition has been given by CDC. Both of them are on the basis of all these GP molecules only. So WHO says if bands are there, antibodies are there against any two envelope proteins. Envelope proteins kaun se the? Ma'am, there was GP160 and GP160 was divided into GP120 and GP41. So any of these envelope proteins, if any two of these come out to be positive, irrespective of others may be there, may not be there, I really don't care, but any two of these come of these GP160, 120, 41 come positive, WHO says that is HIV positive. CDC says that we are giving you a list of 4. Out of those 4, any 2 should be positive. But देखो, out of those 4, 3 तो वही है WHO वाले. 160, 120, 41 वो तो same repeat हुआ. 160, 120, 41. CDC has considered P24 also. So now out of these 4, CDC says that at least 2 bands should be present. So WHO has said that out of these 3, any 2 bands should be there. And CDC says that out of these 4, any 2 bands should be there. So definitely, if I show you this, you will say that, ma'am, ये last वाला strip देखो, इसमें तो none of the bands have come positive. सिर्फ control positive आया है. That means this is a totally negative situation. On the other hand, the first one is almost showing me every band positive, so that is going to be strong positivity. The next one, if I see 160 and 20 में तो आ रहा है, 160 and 120 is coming, 41 is coming very, very weak. Then other molecules are coming like P24. So I can definitely say that this is also positive. So that is how we do the assessment of Western blot, and Western blot is said to be the confirmatory test. So now I want to take you to the last question of HIV which was coming in the exam, and they ask you that someone has undergone a needle stick injury. Needle stick, some healthcare worker, some doctor, some nurse, some intern, someone has undergone a needle stick injury. तो अब कौन सा test कराएं? Earliest test that you should be doing. Everyone ended up marking P24 Western blot. P24 karao, because P24 was there in the options. But do you know what is actually the earliest trace karo? P24 will rise, okay, but what will rise even before P24 is going to be the HIV RNA in the blood. So if HIV RNA is written, you will select that over P24. Please note, the year that the question came, HIV RNA was not there in the options only. So jab nahi tha, to then I had to select P24 as the answer. But if HIV RNA is written, then I will always select that over P24. Okay, if I go back to retrovirus, I had told all of you that retrovirus mein we have 2 things. One of them is going to be HIV and the other one is HTLV. So what are the things about HTLV that you have to know? A quick revision that I'll teach you from pathology. Please note, it is human T-cell leukemia lymphoma virus. So break down karo, what will it cause? It will cause leukemia lymphoma. And which leukemia lymphoma, B cell or T cell? Common sense, ma'am, T cell. So remember, it causes ATLL. Adult T-cell leukemia lymphoma. Wow, such a simple common sense thing. Human T-cell leukemia lymphoma causes adult T-cell leukemia lymphoma via which gene? God has given it a tax gene. That's a previous year exam question. Other than lymphomas, can it cause something else? Yes, it can also cause a non-cancerous thing known as tropical spastic paraparesis. What is the mode of transmission? It can go via blood and body fluids. In fact, breast milk transmission has also been described. Do you remember in pathology what cells were seen? This is important for NEET and INI students. You see the clover leaf cells. The microscopic examination shows you cells which are going to be clover leaf. So if we draw it over here, this is how the cells will look like. The nucleus will have a clover leaf configuration. So that is what you had to know about HTLV1. So the retrovirus family is done, and we have to end our RR with the discussion of the deadly COVID. Trust me, even if you skip it, you're not going to miss out on anything because you already know everything about COVID. So I'll quickly make you scan through COVID in 5 minutes, showing you the basic pathology, microbiology, radiology. Jaldi se let us scan through the 5-6 most important questions. Coronavirus, what should I say about it? Wuhan virus, and I was reading a meme on one of the social media platforms, and like they ask you which travel destination changed your life or which city changed your life. So a person was asked which city transformed your life, and he said Wuhan. That is the impact that this has had on us. So remember SARS-CoV-2. Coronaviridae is the family. No one will ask you. What they will ask you is the genus, and the genus is the beta coronavirus. Now on that note, this is how the coronavirus looks like. I don't want you to go into all the details. I just want you to see that there is a spike protein. Why do I want you to focus on the spike protein? Other than that, there is N antigen, M antigen, E antigen, all of that. ठीक है, नहीं याद करना. Spike protein याद करना है, because even when you look at it under the electron microscope, you will see these projections coming out. That is why the word corona, and the news channels to made like big crowns with jewels on it. That coronavirus is also said to be a crown virus. It looks like a crown. Why does it look like a crown? Because it has petal-like peplomers which are going to be there. Petal-like peplomers are going to be present. So this crown type of appearance is the classical for a coronavirus. Now that petal-like is going to help in attachment. So if someone asks you that these spike proteins, S1 spike protein, S2 spike protein, they are going to come and attach to which receptor of our body? They attach to the ACE2 receptors. But do you know, these spike proteins are little shy. Someone has to give them, introverted hai. Thoda sa spike proteins are introverted. Some extrovert friend will come and will say, acha chalo, let's do some work. Then only this introvert will work. So who is actually going to come and activate this spike protein? We only do that. We are digging our own grave. We have something on our cells called TMPRSS2 that goes and activates the spike protein. That spike protein then attaches to ACE2 receptor. So if I had to write this entire story, what will I say? I will learn that TMPRSS2 is going to go and cause activation of the spike protein, and then this spike protein is going to come and is going to attach to the ACE2 receptors. That is what has been implicated. Now on that note, do I need to tell you this? What are the clinical features? We've been through it, we've seen this, we've experienced it, and no one, we can write long questions on this. Fever, difficulty in breathing, dry cough, shortness of breath, loss of smell, anosmia, all of us had it, loss of taste, it was pathetic. Then later on in the second wave, we also had GI symptoms. Many people had nausea, vomiting. Of course, this is an autocorrect, so there's gonna be diarrhea. So we can, as I said, we can definitely take up a million clinical features, and we are all aware of it. I don't think I had to even teach you this. Chalo, for completion, I have taught you. Now I will show you a few radiology pictures. What do you think? Which is the most common radiological finding that you see? We see multifocal ground glass opacities, GGOs. You can see lots and lots of GGOs over here. Yes, we can see multiple ground glass opacities which are marked over here. And yes, beautifully shown. But can there be something else? So when I say ground glass, have you seen ground glass? वो glass होता है which you can't see through also, but it's not entirely opaque, as if glass has been churned. So it's kind of see through, kind of not, because you can kind of see through this. You can see some bronchovascular markings in the behind, and kind of you can't. But when you can't see anything at all, like this is a complete whiteout. When you can't see anything at all, that is going to be a consolidation. So you can see ground glass opacities and you can see consolidation. In fact, you can see one more thing which I want all of you to note. You can see the presence of halo sign and reverse halo sign. I'm teaching you a little bit of radiology here because COVID, everything is important. What is halo sign? That the center is going to have a consolidation and then there is a lighter area around it. Reverse halo sign ulta hai, that the periphery is going to have a consolidation, and there is a light area inside. तो ये क्या लग रहा है? The periphery is having a very, very dark area, and then the center is going to be light. What do you think? Halo or reverse halo? This is known as the reverse halo sign. These signs are also known as the atoll signs. Tell me, what is this? The periphery is very, very dark and the center is going to be a little lighter. So these are all reverse halo or atoll signs that are present. Now, finally, the last radiological finding, ma'am, the entire lung has been affected bilaterally. This is known as the crazy pavement pattern, and I have written it in this broken line because ये broken लग रहा है. This is the crazy pavement pattern that you see in case of COVID. So what all could you see? Most commonly you see the presence of ground glass opacities. You can see consolidations. You can see the presence of these halo signs and reverse halo sign or atoll sign, and you can see the crazy pavement pattern. So how are you going to do the diagnosis? For the diagnosis, oh, this is traumatic. Everyone remembers this swab and this vial. So you are going to take one nasopharyngeal swab and we are going to take one oropharyngeal swab, and what are we going to put it into? We will put it into the same vial, and this vial contains VTM. What is this fluid? This fluid is VTM, that is a viral transport media. It has some basic growth factors, some basic things basically to transport the virus, ताकि the virus should not die, vital rahe. The virus should remain vital. It has a little bit of sustainability factors in it. Fine. What test was being done? Of course, ma'am, again, you're taking us into trauma. It is RRT-PCR. What is RRT-PCR? RR matlab, this is number one real-time reverse transcriptase PCR. It is a real trial, reverse transcriptase PCR, and I hope you remember at the end of it, there was a CT value also that was given. What was the CT value? CT value matlab, this is not the CT value of CT scan. This is the CT value that the microbiologist was giving you. This is the CT value of PCR, known as cyclical threshold. Means lower the CT value, it took lesser time to grow the virus. The virus amplified very quickly. So lower the CT value, more was the infectivity. It had an inverse relationship. So if the people who had CT values of 10, 12, they had very bad survival. People who had CT values of 20, 22, we were not worried about them. So lower the CT value, we were very, very worried. Matlab jitna kam CT value, utna zyada infectivity. So if you remember, RRT-PCR ka report said positive, negative. Then they gave you a cyclical threshold. Then they also told you what genes were tested. So the genes that were ENS, E gene, N gene and S gene, these are semi-confirmatory genes. Whereas the confirmatory genes were RDRP and ORF1. Just remember, at the end of the report, you had to see RDRP and ORF1 because, you know, some of the labs were good. They said positive hai ya negative hai, clear cut. Some of the labs said E gene is positive, N gene is positive, but RDRP is negative, ORF is negative. So people could not understand कि हम positive हैं या negative हैं. So which are the confirmatory genes that you have to look out for? You have to look out for RDRP and you have to look out for ORF1 gene. So that is settled. But I don't think we remember this test as much as we remember this. So I've kept the most nostalgic thing for the end, and that is the COVID-19 card test. Like any other card test that I have taught you, it has the same principle. Guys, last time in microbiology that I'm asking you, what is the principle of a card test? I have taught you in malaria chapter, immunochromatography. What does control tell you? Control tells you the validity of the test. So ये test ठीक है, ठीक test करा है. The test line over here will tell you positive or negative. Here, so you are getting a test line. So the report over here, of course, we all detected it as positive. This so we can say first hand because we've done it on each one of us, right? On our patients also, on our cells also. So this was the card test for COVID-19, which is pretty much like the card test of any other infection that you have. On that note, with a smile on my face and probably not on yours because you might feel that virology is tough, and that it is, we have come to an end to virology and also to the end to the rapid review that you had. So bacteria, virus, fungus, parasite, general and immuno, all of it has been covered, and now you just need to listen. Trust me, it's a lot of information that I have condensed in this time duration. Even if you've seen the main videos, you will realize that not a lot of things have been left out. Everything has been very beautifully concised into few slides. So now you need to just go through this again and again and again. Listen to it once and then just keep going through the PDFs and the notes again and again, because the more number of times you go through it, every time you will find a question hidden. That is the beauty of the RR that we have for for Path and Micro. So just remember, revision is the game. It's a game of revision. This is one of the recent INI CET toppers who has told me, and that I am always telling all the students that he told me, ma'am, it's just a game of revision. And I understood that, and that is why he got a rank 5. So please remember, game of revision. Pick up these videos, revise n number of times. That is what you have to do. I hope you found this RR beneficial. All the very best, guys. God bless.